Welcome everyone to another edition of Tumor Talk. This is the joint collaborative effort between the Journal of Neuro-Oncology and Lenox Hill Hospital, where we highlight recent publications in the journal and we talk about the rationale behind the studies, the results, and also the clinical relevance as it pertains to neuro-oncology and neurosurgical oncology. And I'm pleased today to have Jackie Young, Dr. Mike Shagru back with us as well, and I'm promoting Dr. Doyen. And today's episode, just like an episode about a month ago, is brought to you by an educational grant by a company named Omniscient, which is a connectomics project. And Dr. Young, why don't you go ahead, introduce yourself and maybe some of your co-panelists, and we get right into it. We like to keep it short and sweet here.
Perfect. Well, thank you, Dr. Miko, for this opportunity to be here to talk a little bit about a paper we have published in Journal of Neuro-Oncology, together with, of course, Dr. Doyen and Dr. Shagru, who are panelists here as well. They are founders on Omniscient Neurotechnology, and I am currently an assistant professor of neurosurgery at Yale. The reason why I got in touch with them was because I did my fellowship in Sydney, Australia with Dr. Charlie Teo, and also at that time, Dr. Michael Shagru and he were also co-founders of the company. And their focus was on trying to really make brain networks applicable to neurosurgeons, something that we were not traditionally trained on. And without further ado, I would like to talk a bit about the paper that was published last year as a series of connectomic lectures. The title of it was Unexpected Hubness, a proof of concept study of the human connectome using PageRank centrality and implications for intracerebral neurosurgery. And I'm going to try to make it very applicable to our audience here, because I assume that the audience will consist of trainees all the way to practicing neurosurgeons. How did this study come to be? Before I go forth, I'd like to say that I have no financial relationships with the company and nor any of the products mentioned in this presentation. Last time, as part of the first part of this series, Dr. Shagru so elegantly talked about the idea of eloquence. Brain eloquence was traditionally, of course, made very famous by Dr. Spetzler, Dr. Martin, when they talked about pre-surgical risk for AVM resection. What areas of the brain should we really try to avoid transgressing? And those were based on experiences of those very experienced surgeons and their knowledge and from their predecessors on if we cut into a certain part of the brain, what would happen? Well, Dr. Shagru in his last talk talked about how he mathematically and using graph theory to try to figure out eloquence. In his finding, basically, it's related to how each part of the brain is connected to another. And then the sum and accumulation of that would equal what we thought of as eloquence, as neurosurgeons, how we were taught in our training. Well, our job as a neuro-oncological surgeon, or all neurosurgeons who deal with the brain, is really trying to maintain function while we're doing brain surgery. And when we talk about function, we don't only talk about being oriented ×3 and being symmetric on motor exam afterwards, but we talk a lot more about how we are or how the patients are after surgery. And with two seminal papers also published in the Journal of Neuro-Oncology with regards to patient neuropsychiatric outcomes after glioma surgery, the field still has a lot to understand in terms of what brain part really is related to different psychocognitive outcomes. Is it just the left side? Is it just the right side? Is it the frontal lobe? Does it matter if it's you're right-handed, left-handed? We're still trying to get a good grasp of that. And on the right side, it basically demonstrates that if patients develop depression after glioma surgery, they actually survive shorter. And a lot of that is, not always part of our understanding and our of our routine follow-up, but clearly it really matters. And a lot of these patients have a hard time going back to normal life, performing normal tasks. Well, why is that? As neurosurgeons, I'm sure we try to avoid eloquent areas as much as possible. But we know that, number one, eloquence, traditional eloquence, one size does not fit all. And this is just a demonstration that actually all of our networks change over time. So not only that, how do we then assume that each part of our brain in terms of their eloquence doesn't change over time? How do we assume that it doesn't change among individuals? Well, in that case, we really need a personalized approach to everyone's brain connectivity prior to surgical planning. So as a second part of this talk, we focused on asking the question, not, okay, can we mathematically actually calculate what brain areas are eloquent? But we asked the question, are there areas that are not usually considered as eloquent, but are eloquent in some patients? So the objective is to examine the approximate prevalence of what we call unexpected hubs. Hubs being nodes of the brain where connections are, and high-ranking hubs would be ones of presumably high eloquence. And we're going to look at areas that were of what we think of as low importance, or at the population on average level, what would be high, what would be low ranking, but in some individuals be high ranking. So this is our methodology. We applied machine learning based parcellations to two normal healthy individual cohorts, so patients without any psychiatric or anatomical anomalies. We ranked their, in each subject, ranked their brain parcellations or each brain parts in terms of page rank centrality. The higher ranking it is, the more eloquent it is. We look at it at a population level in each cohort. We focus on selecting out the bottom half of all parcellations that were low ranking. And then after we have identified those, we look at each individual. How many individuals would actually demonstrate high ranking for those otherwise low ranking parcellations on average? And that really is the simple but yet significant question at hand. And this is an in silico experiment where we just looked at normal population. So this slide shows that we've, number one, tried to see if the parcellation scheme works on both cohorts. And we tried to find the top 10 ranking parcellations. And indeed, they review the usual suspects of eloquent areas, such as the brainstem, for example, or the entire cerebellum and the thalamus. And it's more or less just a proof to say, hey, these two cohorts, they demonstrate regular brains and they exhibit behavior which we would normally expect at a population level and on average. These are average rankings. Now we try to look at, okay, we select out parcellations that are low ranking, or what would be mathematically presumed to be low eloquence. We look at how often do they actually appear in the very top quartile of ranking. And it turns out that depending on which cohort we look at, that kind of phenomenon can actually happen in from 30 to 40% of patients. So in 30 to 40% of patients, they can demonstrate low ranking, otherwise what we think as low ranking parcellations or non-eloquent areas. For those patients, actually they have high eloquence. All right, so next, of course, we can look at each individual parcellations, and we try to look at, are there specific ones that actually appear in more than 3% of the subjects? Once again, very low ranking parcellations that are highly ranked in normal individuals. And turns out, yeah, there are 3 that really stood out. They would include the left V6 area here on the left A10P, which is in the anterior pole, and then the left 7PL as part of the superior parietal lobule. V6 normally thought of as being in charge of processing and analysis of visual motion, A10P episodic and working memory tasks, 7PL vision, motion, space, vision shape, attention, and working memory. So one thing of note is that, okay, these are not really traditionally thought of as being related to motor function, language function, which we automatically equate to eloquence, but certainly these functions are very important to us as human beings. So what are really the take-home points from this paper and this study? Number one is that, yes, there are unexpected hubs, otherwise low-ranking parcellations that can be high-ranking in as high as 8% of all individuals. And a common feature among these 3 parcellations that we have just empirically looked at was they're all on the left side, and they are all connected to another part of the brain via the IFOF. So the IFOF, as we now know, is very important for a lot of our semantic language processing, etc. And that eloquence can vary among individuals. And a lot of times they're not speech or motor related, but certainly are cognitively essential. And this really just goes to speak to the need for a personalized approach to understanding brain connectivity prior to proceeding on to any kind of intracerebral surgery. That would be the end of the talk.
Thanks so much, Jackie. I think you've done a really nice job, obviously, with the paper. And, I speak on behalf of Jason, who's not with us today, but, it's a privilege to be able to publish this quality work in the Journal of Neuro-Oncology. I think it's extremely forward thinking, and it's a new topic, and people don't fully understand it, right? We're neurosurgeons. We operate with, steel and string still. So it kind of goes over our heads. I guess, we'll allow the viewers as well to ask questions. We'll open the chat to that. I like to lead it off, I guess, with a question of, 8 to 10% or so of patients, it seems, have these areas, like you said, that we would traditionally consider non-eloquent. We would traditionally just resect without a question. Are you using now connectomics on all your dominant hemisphere brain tumor cases, or are you using it on all cases? How does this information inform your clinical practice moving forward?
Well, thank you for the question. The question is whether it's this type of personalized brain mapping, whether it should be used on all patients and all comers. And the answer is very clearly yes. The reason why is because right now we don't know what we don't know. And it's a lot of times we never thought about those areas as being eloquent because we never looked for the neuropsychiatric deficits that come after it, because we never traditionally, for most centers, looked at detailed neurocognitive assessments of these patients. So if we don't look, of course, it's not there, but only with the accumulation of all of our collective surgical experiences using a software such as QuickTome, do we get to start compiling our insights into, okay, all right, so the software eventually going to tell us this area actually is quite high in hubness or centrality. And then we would start looking into, okay, all right, that makes sense. 4 months later after surgery, these patients are still having issues paying their bills and writing their checks, which we, of course, never look at. So yes, certainly on every patient. And I think we can only grow as a field if we all participate in this, using this sort of approach, actually.
Yeah. You kind of already got or alluded to my next question, which is, in some of these patients, you obviously looked at the lowest ranking that ended up being high centrality, right? What about the ones in the middle? Are there regions that, maybe you looked at that aren't mentioned here that you were surprised to see further up on the list, not just IFOP? Is there a spectrum of these areas, right? Is there something, that's not as central, maybe in the middle ground, that may contribute a lot to some of the cognitive dysfunction we see postoperatively?
Absolutely. So during the this in silico exercise, there were indeed quote unquote middle ranking parcellations that were high ranking in some individuals. And truth be told, it's related to the first answer is, clinically, what exactly does that equate to? We quite don't really know yet. And I can but for sure, I can tell you those middle ranking parcellations on average certainly are high ranking in some individuals. And I think this only creates more excitement onto where this field is heading.
Yeah, I mean, it'd be interesting to see, and I'd have to think about it for a long time, but to measure the variability, right? To look at how variable this is, because you found 3 consistent ones across a large population, but what about the variability between patients, right? Are there, maybe it's not all IFOP, or maybe it's different parcellations within IFOP that are subsequently, important or more central, as you kind of put it in terms that you use in the paper. I mean, any thoughts on that?
Certainly, and there is certainly patient variation, because in the end, the concepts is that our brain connectome is, it's what is it made up of? It's accumulation of course, our genetic differences, that's for sure, based on our different ethnicity, based on our different upbringings, which brings to the point of environmental factors. And then, of course, the other aspects as for neuro-oncological surgeons is actually mass effects. If it's a low-grade glioma, things can change. So there can be so many variations and factors that go into it. And I mean, it's hard to answer the question specifically, but there can be so many variable factors to why everyone's connectome can be different. And the clinical significance of all of those things really needs some time. And of course, Dr. Shuguru has been spearheading the glioma connectome project, and I'm sure that will shed a lot of light into this question as well.
Yeah, I mean, I'm obviously super excited to see the results of the work you guys are doing. I do think, this paper, even though, again, 8% is kind of on the smaller side where you see the consistency of these lesser known regions, it's super important because I think it really does highlight the importance of precision medicine, right? These happen to be consistent, features across a number of patients, but like you said, and like I'm alluding to, is there's variability, number one, and that's what this paper argues. And then number two, that middle ground has not been properly evaluated. And so, I think, you have to have conversations with patients about their goals, what it means to have a quality of life. And I agree. I think neurocognitive testing is super important. We ignored this for so long. I mean, how many of us have done a left frontal lobectomy, language sparing, obviously, and without second thought. And maybe, there should be a second thought.
And I think I would ask the audience to think about this, is that how many times during either their training or during their practice, they can perform this same type of surgery on 10 patients. There's always going to be one patient or one or two patients who wake up very differently, excessively confused, or have troubles, some sort of trouble that you would not expect from the majority of other patients. And this is perhaps shedding light onto why that is. The exact same surgery, but slightly different outcomes.
Yeah, definitely. So I got to ask you, what's in the future for this? Where do you see this research going? What are kind of the next steps for your involvement in these types of studies?
Certainly, I look forward to seeing how once the QuickTome is able to incorporate, of course, Dr. Doyen and Dr. Shuguru can speak more to this, is that once this type of centrality ranking can be more incorporated into our surgical planning, then we start thinking about, all right, the areas around the tumor, if we're looking for very super maximal resection, the areas or the margin of it, are there certain parts of the margin which actually has embeds these unexpected hubs, and where we should actually, maybe that part of the margin, we should be a little bit more conservative instead. So clinically, that would be one thing that I think would be on the horizon, especially since there's now there's a resurgence of literature on supramaximal resections. So that would be more on the near future, I would say.
Yeah. Yeah, Dr. Chagru, Dr. Doyen, any other comments? I'm curious if you guys have anything to add today.
I mean, I think the first thing is, as a historical note, Jackie wrote this paper originally in hotel quarantine in Australia. So, you know, like I said, don't ever say that COVID lockdowns didn't lead to anything. I mean, look, there's the Decameron was during the plague, and Jackie wrote this paper, so it's a follow up to Boccaccio. I think the key thing to think about, I think about with this paper is, I remember there was a patient, and I can't remember what it was, but essentially it was like, it turned out it was a patient that had an MS, really bad case of MS, and turned out that she also had a glioma that developed in it. And we knew it was a glioma because it started expanding. But essentially, it wasn't very big. And I went in and we started with, say, we're going to do an open biopsy and see what it shows or whatever. So we did that. And I think I went down to sulcus. I took the absolutely the smallest biopsy in the history of neurosurgery, and we closed. And afterwards, everything was wrong. And you get into these things where you say, there's no way that's true. I did almost nothing. And, you know, maybe it's the air hits your brain and this patient's, you know, traumatized by this thing. But the reality is, inevitably, we all have some case like that where you think there's just no way. Like, I take lobes out of people who are like, thank you, doctor, and walk on and go on with their life. And then this person has all these issues, right? But I think what we get down to is, remember that the brain is extremely complex. And I think that our idea that we can simplify this into simple paradigms that make sense to us intellectually, when remember that the working memory capacity of an adult human is 7. We know that. That's why we have 7 digits. And a number that's the working memory tasks start at 7 digits is a normal span. So if we can handle about 7 things in our head at once, but there's 100,000 things or 200,000 variables we need to account for, the brain isn't designed to do that. Brain isn't designed to study the brain. And so you need agents, and because otherwise you don't know what you don't know.
I love it.
From my end, at least, so disclosure, I'm not a neurosurgeon, but I did formerly study neuroscience. I'm more of a machine learning practitioner. I think it's although proof of concept, this is an excellent example of things to come, in the sense that, you know, page rank centrality, it's something that's been around now for several decades. It's actually this algorithm is what made Sergey Brin and Larry Page rich, and this is what's propelling your search on Google. That's why you find the top link, right? And so we've seen that around in technology for a while, but there was never really an application for it in the field of neuroscience. And now that we're bringing methods that are more standardized, we're bringing cloud computing, we're bringing all those approaches, and also we find you know, fruitful collaborations between technologists and neurosurgeons. We start to see some really cunning and appropriate applications coming in place. And I think this illustrates what we'll see more and more in the future, that is technology serving neuroscience rather than the other way around. And you know, I'm glad we're able to present this work here today, brilliantly done by Jackie. So thanks.
No, thank you guys for being a part of this. One last question, and it gets to, you know, we're obviously talking about, in the end, cortical regions and tracts, right? And so we mentioned the IFOF as being obviously critically important in terms of this paper, in terms of areas of centrality. What is QuickTome, or what does the understanding the connectome allow us to say about plasticity or rehabilitating these tracts, right? I mean, these are ultimately hard wires that are going between places, but we know that there's neuroplasticity. And so what are kind of the implications of this, you know, beyond or after surgery, and moving into, you know, recovery of these networks, or especially in lower grade lesions where that's a possibility, or even rehabilitation of these networks?
I mean, I think one of the things to think about is we don't really know what neuroplasticity is. I mean, yes, is there some kind of neurogenesis going on? I mean, it's possible, right? But more likely, if you think about it this way, right? So let's just do a simple thought experiment. So, and there's data to back this up, but when Wernicke's area talks to Broca's area, how does the signal know where to go? Right? Who's the conductor? Well, there's no evidence that anyone's ever found, that I'm aware of at least, that there is a conductor. So what happens is when Broca's area tries to talk to Wernicke's area, the signal gets propagated on all possible paths, but the shortest path usually dominates because it basically is faster than the other ones, right? And eventually that path gets upwired, and that's how we learn, right? So let's say you damage the system, right? And now Broca's area doesn't have a direct connection to Wernicke's area, or has less of a connection. Well, inevitably, some other pathway is going to upregulate over time, if it's possible. Now, that's a wickedly complex problem if you start to bend your mind around, well, Broca's area doesn't talk to Wernicke's area. How do I get them to talk again through a different collateral pathway? And which one is the right one? So what we know, again, is that if you disconnect and destroy the architecture such that there's no path, or there's no neural construct, like you remove this central executive network or something, or the default mode. And, the reason the DMN talks to itself is it's the shortest path between those two areas, right? That's why those areas are heavily wired together and they talk a certain way. The answer is, if I destroy it, then there's no way I can rehab around that. But a lot of times, some of the deficits that we see are collateral. So some areas, A and B don't talk to each other correctly because C was regulating how A and B talk to each other. Now you don't have C. And so then what do you do with A and B? And a lot of times that's actually very rehabable. So the network is there. So I think the first part of we start thinking about post-surgical rehab is you need to maintain the architecture. If you do a bad surgery and then expect something like TMS or DBS or whatever, stem cells, you think of whatever you think about, to come in and fix that, that's probably unrealistic. But what we find a lot of times, we're doing TMS with this, is that a lot of the challenge is not usually corticospinal tract injury in people who are hemiplegic, for example, it's dyssynchrony. And dyssynchrony is a treatable problem because the rest of the architecture can just be reset. And that's something that we found seems to work, and we've published on this, et cetera. But I think that that's going to be the future, is being able to think in terms of a complex network to the extent we can, and then begin testing that with data. Because inevitably, some of the people who are paralyzed are not paralyzed because the motor system is damaged.
Great. Guys, I can't thank you all enough. It's the 30-minute mark. We like to keep it short and sweet here. This lecture will go up on YouTube, and it'll actually be housed on the Cassini webinar series now. We're going to be moving the platform over to that. It'll be both YouTube and Cassini. And so it can be rewatched in those two settings. Always a pleasure. We have one more session coming up in a couple weeks' time. We want to thank again Omniscient for the educational grant, being able to push forward these kind of very forward-thinking studies. And we want to thank you guys for considering the Journal of Neuro-Oncology. And it's always a pleasure. So thanks so much.
Thank you very much.
Thanks,
Have
everybody.
a great afternoon. We'll see you all next week. Bye-bye.
Thank you.